Chairman, dear colleagues, in contrast to my previous speaker, I'm not an electrophysiologist, but one of my tasks is also to talk to both the electrophysiologists and the patients. And the topic of this talk is actually the clinical utility of this innovative device and the IT setup which you actually need around it. And because we are in Europe and because the wearable ICD is not readily distributed in all the countries, I will show you a little bit of the ICD itself. I will add a little bit of new data and I will enrich the discussion with a few cases. So you've seen this slide, but I would like to point out that this is really a very elegant and easy tolerable device. So it's like a pullover. It has 3 electrodes, 1 in the front, 3 in the back. You have these self-gelling gel capsules. It needs to have a tight fit, but it's still comfortable. You have 1 cable here, which mounts to this defibrillator monitoring unit at the belt. And if you wear it, you can actually go to the theater without making a bad impression. So this is the first case, a 62-year-old male patient who suffered from pericarditis and developed cardiomyopathy, had a depressed LV ejection fraction, AV block, and intermittent tachycardia with atrial fibrillation. And he had a comorbid problem, which is a manifest hyperthyroidosis with autonomy, and this put him at higher risk of malignant arrhythmia. So this patient actually was prescribed a wearable ICD, and very soon in our center we were lucky that we actually had prescribed him this one. You can see the incipient tachycardia, and then it takes some time, a little bit more time, and then the shock occurs, and within a very short period of time, the sinus rhythm is restored. So this was a life-saving procedure, and of course, if you have proven that it's that malignant, you are more confident to recommend, in this case, a monolead ICD. So the ICD is wearable. He's able to deliver up to 5 shocks, 150 joules, R-wave synchronized, and we've heard that the patient actually can withhold therapy by pushing a button. So that's very elegant. We've seen one slide of the varied registry, but I think it's important to get a little bit deeper into it because it's one of the largest collections of data, and we have very good information on ischemic, non-ischemic, and congenital heart disease patients. It's from the group of Arthur Moss, who's also famous for the MADIT trials. And what you can see here, that in these 2,000 patients, you detect about 30 events in 22 patients. So this is a, let's say, a success rate, life-saving success rate of 1%. So in these patients, shock has occurred and has saved lives. But in addition, and that refers to what Dr. Helms already mentioned, the wearable ICD has lots of other information that the tool can collect and which can be used in practice. And it's summarized here. If you sum up these percentages, it comes to 7.4 or 1 in 14, where you actually get additional information which will help you triage the patient into additional diagnostic or therapeutic strategies. And it covers sustained VTs, non-sustained VTs, atrial arrhythmias, and also severe bradycardia and asystole. So in practice, this means that if you have 100 eligible patients for the wearable ICD, 2 of them will experience a sustained VT, and 1 of those will be shocked, appropriately shocked. And the other one is a likely candidate for an ICD. 1 patient will have a non-sustained VT, and such patients usually are referred to the EP department, and if inducible, they also are candidates for ICD. And there's also a considerable proportion, 4 patients will experience SV arrhythmias. They usually require more evaluation. Ablation might be an option. And also one patient might develop severe bradycardia and will be a candidate for a pacing treatment. So one large output of the varied registry is this kind of information. It has been mentioned before that a sizable proportion of patients actually improves LV function over time. So with a variable ICD, we buy this time. We know the patient is protected. But on the other hand, a sizable proportion will not improve, and we can collect further arguments why this patient actually should have an ICD. And we have been referring to the complications of the ICD. That's a very important point. So we should make sure that actually the benefits get the ICD that will benefit from the intervention. Very recent data, only 4 days from the same group, stems from the SWIFT registry. And it has a little bit of a new aspect to it because in this registry, severely compromised patients were looked at, class 3 and 4 patients, with additional criteria underlining the severity of the disease. It's listed there. I'm not going into details, but they were ischemic and non-ischemic patients. The non-ischemic, again, refer to the Danish trial. The non-ischemic were a little bit older, 30% were female, severely compromised, and heavily reduced LV ejection fraction. So these subjects actually received a variable ICD, mean wearing time 60 days, 18 hours per day. And the question is, you can look up in your mental history, do you have such patients? This is a patient of our center, 72 years. He received a first diagnosis of heart failure. CAD was excluded, so dilated cardiomyopathy, severely compromised global hypokinesia, severely depressed LV ejection fraction, dilated left ventricle, and elevated pressures. So severely compromised patient, but again, with some comorbidity. And yeah, we mentioned that we have to be quite confident that actually we do not induce a ICD too early, so we have to be comfortable with the decision. So this patient had a basalioma, but it was ancient, longer time diagnosis, and it looked really bad, so we didn't know what was going on here, and had a mild lymphoma discovered by incident. So this patient actually got a variable ICD to cover the distance needed for further diagnostics, and only a short time later he developed this non-sustained VTAC, and we knew this is a patient at risk. We completed diagnostic, and ICD was implanted. So this was a nice example how this kind of approach actually helps us corroborating our diagnosis. Back to the SWIFT registry, the authors concluded that about 7% of patients will suffer from severe arrhythmic events, which can be discovered and appropriately treated. And also here in this patient population, 28% patients received the ICD. So the authors concluded, I think that's a nice conclusion, although it must be confirmed in larger registries and trials. Each day of wearing the ICD, the variable ICD, was associated with an adjusted 1.5 decrease in all-cause mortality risk. And if you look at this table here, you see that you again have a differentiation between ischemic and non-ischemic etiology. And this is a very important group, the non-ischemic patients. And the SWIFT registry seems us to tell that it's sizable, but it's a smaller proportion which actually will benefit from an ICD. And with the help of the wearable device, you can better define which subgroup will benefit from this strategy. So if you decide to prescribe a wearable ICD, you have to also make sure that you have a live vest network, so it's called, but the beauty is it's very easy to set up. So part of the network is the patient itself with a vest, with a monitoring station, and it's Bluetooth technology. The patient is at home, signals are transmitted to a server, to a cloud, and can be viewed by all the authorized staff which is entitled to do so. And you also can select who is actually receiving the information. In Germany, it's usually a dedicated nurse reviewing the events and then telling the true rhythm events. And you can trigger off alarm to dedicated subjects, staff, the nurse or the doctor directly. And the important thing is, of course, that the information is viewed and judged, and then the appropriate action is triggered and the therapeutic decision is made. Again, this strategy allows us to collect this very important clinical information at the earliest point in time. So this is very elegant, and I also like the possibility to introduce also manual recording. So the patient is involved in telling you, this is something fancy, I'm not sure about this, please look at this. It comes with a dashboard, which is intuitively to manage. It allows the clinicians to triage the thresholds and tailor the alerts, notifications as mentioned. And what is also very elegant is that with one view actually see whether your patient is compliant. This is one day, and if the column is filled, compliance is excellent, the patient is wearing the vest, he is safe, and we are reassured. And so here the density is very good compliance. Here somewhat more fragmented compliance during certain days, certain times of the day. And this is a patient with bad compliance. You actually should talk to this person because 8 hours of wearing the device is not enough to being protected. Of course, you can receive customized reports, and that can also be fueled back to the patient and can enhance communication. So in summary, this is a very elegant tool, and I would like to come to the end with 2 more cases. One is a 34-year-old male who had a lightning stroke accident. In hindsight, it was not clear whether how close he was actually to the lightning bolt, but apparently he felt faint after the incident, and after a few days he developed first intermittent and then persisting atrial fibrillation, quite tachycardic, and the peripheral hospital treated him with repeat electrical cardioversion, and then because it came back again and again with antiarrhythmics. So we saw this patient. He was still quite fast with atrial fibrillation, multiple PVCs, long QTC interval. On echo, he had a modestly increased left atrium, compromised LV ejection fraction, elevated anti-proBNP, and of course, regular pharmacotherapy was started, digitoxin was added, and a life vest was prescribed. And then in the course of very few weeks, LV ejection fraction improved up to 53%. So we felt very comfortable with this, and with the help of pulmonary vein isolation, this patient was ultimately treated and is fine now. No ICD needed. And the last one is courtesy of Dr. Sperzel. I'm just referring to this events with the bradycardia because it's a very useful feature of the wearable ICD. This patient presented to the emergency room after a syncope, only minor injuries, normal electrolytes, normal CT scan. But it was apparently an MI patient, successfully treated, but with compromised LV ejection fraction. Pharmacotherapy, including beta blocker, was installed. And when the patient was seen, LV ejection fraction was still low. LV was dilated. So intuitively, the first idea would be maybe it's ventricular tachycardia causing syncope. And then talking to the EP guy, Salpfor, he recommended to discharge the patient with a life vest. And we mentioned it before, the algorithm of the vest, it's called asystole, but it also can detect heart rate below a certain cutoff for a certain time frame, and you can get a report what is going on in the background. And what happened that a very short period later, patient-initiated tracing, so he pushed the button, happened. And you can see it here on the report. There were 2 of these tracings and another 5 episodes of asystole while the patient was sleeping. So we had the robust information that this is actually something which needs to be taken care of. When we looked deeper into the ECGs, significant bradycardia was found and a permanent pacemaker was implanted. So this is also a nice example how the patient triage actually is supported by the wearable ICD. Ladies and gentlemen, let me conclude that we have with a wearable ICD an innovative tool which can protect patients from sudden cardiac death. It can save lives. We have an elegant system, a remote management patient system, which comes with it. So the management is elegantly supported. It provides not only therapy if indicated, but also diagnostic information. It provides us with actionable information, so we are getting useful help how to actually triage the patients onto the diagnostic and therapeutic pathways. We buy time for the decisions, and we are confident that the patient is safe for this time. I just remind you that 41% of the patients demonstrated an improved LV function over time. They did not need an ICD. And the 42% actually who did not recover, they will have the most benefit from the ICD after implantation. Thank you very much for your information, for your attention.